and thank you for joining us today. We are thrilled to put on this latest of our webinars here at Chilmark Research. This one is being done in conjunction with PREDICTIVE Health, who helped coordinate and bring this together. It will be on a very important topic, as you are all aware, looking at how healthcare AI is going to be both utilized but also affected by what has happened recently with the COVID-19 lockdown and global pandemic. So we have some great panelists with us today who I will introduce shortly. Today's speakers are Jody Rank, a senior analyst here at Chilmark Research, who has a doctorate degree in public health and has really been focusing on more advanced analytic technologies for the last number of years here at Chilmark Research. He wrote a report on artificial intelligence and machine learning and the opportunities there in healthcare back at the end of last year. And he has also written a number of other reports with us as well. And then we have Susan Athey from Stanford Graduate School of Business, Colt Courtwright, who is the Director of Corporate Data and Analytics at Premier Blue Cross, and Linda T. Hand, the CEO at PREDICTIVE Health. I will now hand this over to Jody, who will get a little bit more detail about himself, and then each panelist will introduce themselves, and then we'll go into the presentation, followed by an interactive discussion that will field questions from you, the attendees.
Great. Well, thank you, John, and good morning, everyone. I'm Jody Rank. I have worked in global health for close to 30 years. Have done, as John mentioned, have been covering the AI and analytics space off and on over the past several years for Chilmark. I also work a lot in digital health, sensors, vital signs monitoring, and I have a connection to AI in that space as well. And now I'll turn it over to Susan if she'd like to provide an intro as well.
Hi, I'm Susan Athey. I'm a professor of economics at the Stanford GSB. I'm also associate director of the Stanford Institute for Human-Centered Artificial Intelligence and the founding director of the Goal of Capital Social Impact Lab. And I've been spending a lot of time developing methods to apply AI to causal inference problems, where we try to understand what works for whom and why, and to apply those techniques to various social impact problems. And I'll come back to what I'm doing around COVID-19 as we go through the discussion.
Colt, if you'd like to go. Colt, your audio is off. Got on mute.
There we go. So I'm Colt. I lead data and analytics at Premier Blue Cross, which is a blue health plan with primary operations in Washington and Alaska. We insure about 2.3 million individuals, and because of our particular client base, with companies like Starbucks, Amazon, Microsoft, Expedia, we actually ended up supporting members across all 50 states and US territories. My background is really building data and analytic teams, data science competencies, interoperability, and clinical data strategies.
Great, thank you. Now, Linda.
Yeah, Linda Hand. I'm the CEO of PREDICTIVE Health. PREDICTIVE powers proactive healthcare. We enable employers, providers, health plans, solution providers to understand their future risk. Customers use our solutions to accurately stratify their populations, to target more effective outreach, to personalize communications, to differentiate and win new business.
Great, thank you. If you could go to the next slide, John, and we'll, here's our agenda for today. I'll be providing a brief introduction to AI and some of the use cases and emerging issues. And then we'll segue into the post-COVID opportunities, where we'll have a bit of a roundtable discussion on a number of questions with our panelists, and then we'll open it up to the audience. If we go to the next slide. So this is sort of a more detailed slide on the introduction. And now I'd like to start with going quickly to the next slide, John, if you could. I want to begin with why AI and why AI now. And essentially the value proposition that AI can provide is that we can have better analytics at a lower cost. It basically brings down the cost of prediction in healthcare and predictive analytics. And we also are able to ingest larger volumes of data and include thousands more variables in those analyses, which ultimately leads to better predictive insights. And one of the first areas beyond sort of radiological imaging and applying sort of the insights from deep learning to from facial recognition and image recognition was the area of chronic disease management, especially diabetes and congestive heart failure or heart disease, and helping providers and payers avoid high utilization rates and unnecessary hospitalizations. So we can scan through the EHRs and ingest data from outside the EHRs and flag patients that may be at higher risk and may need additional types of preventive care or the ability to address care coordination gaps, for example. And also payment mechanisms and just broader patient safety and welfare. The issue of readmissions has been a very important area of focus for a lot of AI vendors. And then there's the classic case of hotspotting that initially was done with the Camden Healthcare Coalition years ago that Atul Gawande wrote about in sort of extending the predictive analytics into the community and finding areas where or patterns that may suggest certain communities or neighborhoods, individuals may be at risk. And even though a recent evaluation of the hotspotting case of in Camden suggested that the results were not as important as or not as impactful as we originally thought, it's still an important methodology, especially in this post-COVID environment, which I'll get to, or during the COVID epidemic and post-COVID epidemic as well, for a variety of reasons. We also see use of AI and behavioral health interventions in areas such as mental health and substance abuse. When we were working on our AI report, we found an example of a company called Dynamic Air that used facial recognition to validate a certain user in a substance abuse program and do the testing remotely versus having them come into a center. And then all the data from that patient's behavioral interventions, programs, and so forth went into a typical sort of population health management dashboard where providers could monitor a cohort of patients and intervene if they saw someone who is in need of assistance. Social determinants of health and broader access to care is another important area as well, where we can use AI, such as natural language processing, for example, to scan medical records and maybe flag issues for a particular patient where a particular social determinant may get in the way of them accessing care or being able to comply with, let's say, a chronic disease management program and so forth. But we also see even broader examples of AI with social determinants and having the ability to bring in EPA data, census tract data, and so forth, and understand community vulnerabilities to chronic diseases and even coronavirus based on what we know at the time about the dynamics of the virus. And this gets us to one of the big problems we've seen with our health system in general over the last several months since the pandemic hit was the lack of preparedness we had to extend the formal healthcare system into the public health surveillance system, and a lot of gaps there that have hindered our response and general preparedness and response to the pandemic. And we'll be talking a bit more about that in our question session, and looking at how we move data across these disparate systems. So if we can move to the next slide. So who are the main stakeholders for AI across the healthcare system? Well, we see payers who are using it in both the use of chatbots for consumer education about their health plan details. And we see the use of AI in claims management and automating adjudication, taking a lot of these processes that are manual and quite cumbersome, and using AI tools to automate and bring down both error rate, improving accuracy and bringing down error rates, but then moving the claims through the system much faster. We see examples of use in behavioral health and payments, and like payment integrity and detection of fraud with Medicaid and so forth, as well as using it to pinpoint members who could be at risk of higher utilization, and finding ways to optimize care while also lowering costs. Physician applications include everything from clinical decision support, diagnostics for radiologists. That was one of the early areas where AI was applied because of the advances in imaging applications of AI. Population health management, as I went over in behavioral health applications, where you can ingest data from the EHR and maybe a patient's wearable device, or some sort of remote patient monitoring, and then get those early signals when things aren't going as well as they should, and intervene earlier. We also see applications in hospitals for optimizing bed allocation and human resources, and managing the shifts of doctors and nurses in ways that can help reduce burnout. As well as on the burnout issue, there's a lot of work around using natural language processing for voice assistants that can help physicians with the clinical documentation in EHRs. In clinical research, there's a wide variety of applications, from research tools across in precision medicine and the various omic sciences, given the volume of data, and sort of achieving research goals much faster. Clinical matching of patients with the right clinical trials, and then in drug discovery and development, which we'll discuss more in the questions as well. And we see AI permeating increasingly the public health world, and we're talking about the emergence of precision public health, better modeling of the pandemic. And then a final stakeholder would be the health IT vendors, who are increasingly looking to AI to develop better tools for clinical documentation, searching the medical record and making that much easier, and automate, and as I mentioned, automated data entry for physicians. And if we go to the next slide, here we want to talk briefly about some of the challenges with AI and machine learning. In the report that we released earlier this year, we discussed a lot about how there's a lot of rhetoric in the marketplace about where AI is, but in healthcare, we really are in the early days, and it's not as mature as it is in some areas of the economy, but it is definitely advancing at its own pace. But where we see the greatest adoption right now is in business operations, less so in the clinical decision support. And one of the reasons why that has to do with the general maturity of the underlying algorithms and models used in AI, where the models based on causal inference are really much more in the earlier days, and the models you can make associative analyses. And for a lot of clinical applications, we really need to know why we're seeing a particular outcome, or underlying mechanisms, and move beyond associative types of studies. There's also across the AI world, this extends well beyond healthcare, is the issue of bias and transparency. And last October, a particularly important article in studies/article in Science magazine illustrated this quite well, where there was an algorithm used to analyze risk for over 200 million patients. And this risk scoring of patients actually had some built-in bias that adversely affected African American patients. And so there's a lot of attention in both the data science world, so forth, to really work hard to start rooting out some of the historical biases in both clinical studies and clinical trials. but also of in the development of algorithms themselves. So we have fewer gender, race, ethnicity, so on, biases in the recommendations or just the general outcomes of the analytics themselves, and eradicate any potential bias that exists. And then somewhat related to that on the ethical front is the issue of transparency. A lot of algorithms are black box algorithms for IP concerns. Companies can't just open up and say exactly how this works, but there's a growing discussion about how we need to think about explainability of how systems work so that patients and providers understand how this system is delivering a certain output. And then a final area is the general issue of data access, governance, and privacy, which involves when we're working with this dramatic increase in volume of data across different providers or health systems and so forth, governing the use of that data and safeguarding privacy and security is fundamental. So there's actually even technological innovation in areas such as federated learning that help us share data while also maintaining the ability to anonymize data and maintain privacy of records. But this is clearly a difficult roadblock in many cases, and we'll get to that in some of our questions. So if we go to the next slide, getting to our post-COVID or the midstream COVID world, where we see AI playing a role in what we're going to get to in our discussion, a number of issues from everything from modeling the epidemic and understand where outbreaks are and managing issues such as ICU capacity, understanding the social effects of mitigation and risk stratification at the community level. And we're seeing that African Americans, for example, have been hit much harder. And so there have been tools created that understand community vulnerability with access to care, air quality, and environmental factors that may also increase vulnerability to COVID. And we saw several months ago, Javion, for example, introduced a community mapping, vulnerability mapping tool in this light. And then understanding the lockdown and stay in place policies and the effects on chronic diseases and delayed care or lack of access to care during these lockdowns, and how we understand risk coming out of this and which cohorts of patients may face a greater risk burden due to this delayed seeking of medical attention and so forth. AI is also playing a role in drug and vaccine development and helping to understand interactions with the virus, specific molecular interactions with the virus, modeling vaccines and drugs, dosages, in a various number of ways to both find compounds that could be useful as drugs, but then accelerate the vaccine and drug discovery process. And then we see, as the pandemic progresses, a lot of long-term health effects of the pandemic or of the virus on different cohorts of patients where it attacks different organ systems differently. And so understanding these sequelae that may be long-term, AI will be important for ingesting data from large volumes of electronic health records and helping us to understand the patterns and treatments that work and so forth. And it also plays a role in that virtual care when we have that virtual care that is taken off during the lockdowns for obvious reasons, but then having more data collected remotely and ingesting that into the system so that it can be, we can provide actionable clinical data to physicians providing virtual care. And I think we'll also see a lot of work going forward in modeling cities and regions at this nexus of public health and city planning, given how we have to respond with the social distancing and so forth. So now I want to open it up to some of the questions that we have for our panelists. And the first question we mentioned it's been both, we're in the early days of AI's usage in healthcare, and also in the first several months of this pandemic. So where do you see AI potentially making the biggest input in or the greatest inroads in the fight against the virus and kind of providing better healthcare during the pandemic? So anyone want to go first?
Sure, I can jump in on one thing that I've been spending a lot of time on is trying to use data analysis to understand the impact of treatments through the pandemic. So we can think about, even while the people are in the lab trying to develop new molecules and new treatments, we've still had a lot of attention early on that we can already study repurposing existing therapeutics. But it's turned out there's been a lot of challenges to making that happen, and solving those challenges would provide a lot of upside. So if we think about repurposing therapeutics, we need to have evidence, but getting data for that is challenging because the claims data comes with delay, and it's rolling in now, but there's not as many patients coming in anymore. So you really want to get real-time data, but then the real-time data is distributed in EHR systems across hospitals. In principle, if you had everything set up in advance, using AI techniques like federated learning, and if we had similar data structures, it wouldn't be hard to run models across different hospital systems in order to get the benefits of modern AI techniques. But just getting the contracting going, finding the right people and setting it up takes as many months as waiting for the claims data to arrive. And so we kind of had a missed opportunity to do real AI analytics through the height of the crisis, which then puts us into a time period now where, from a data perspective, we're sort of short on patients. And so now to try to make use of data insight is more challenging because the patients roll in more slowly for trials and analysis. So we kind of missed the window where we had a lot of patients coming in. Just to kind of highlight a little more what the AI really needs to do, what is the hard work it needs to do? Why can't you just study one hospital at a time? When you're looking at repurposing, before you get to a trial, a lot of times you need to do retrospective analysis to think about safety and get some signal about efficacy in order to prioritize the trials. But if you want to study drugs that people were given as a last-ditch effort in the hospital, that's going to be a very challenging thing from a causal inference perspective, because the people who get lots of things thrown at them right before they die are very much sicker than the other patients, and so it's very hard to learn the causal effect of those drugs that are getting kind of put on at the very end because they're responding to the patient's decline. You would like to look at things that were given earlier. And that might be patients on chronic conditions. But if you were taking a drug for a chronic condition, I need to understand your medical history and the medical history of patients who weren't doing that. And the hospitals don't always have a full data stream on the patient's history. So that can make that hard to study. And generally the patients on chronic conditions are different than the patients who aren't on chronic conditions. So you need a large data set and a well-designed data set, a complete data set, in order to conduct those kinds of retrospective analyses. So with a research team, we've been doing those kinds of things, and we've managed to piece this together with a few systems, but it's been slow despite the fact that we've been working 24/7 since March. It's just been hard to get enough data to make the statistics work well enough. But I think from the opportunity perspective, after this pandemic, perhaps we will have laid some of the groundwork, or in the second part of this pandemic, we will have laid some of the groundwork. We will have agreed on some of the data structures, the data frames. We will have figured out who the collaborators are, and we will be able to run larger scale analyses across different systems. So those are just a few of the challenges. There's a few other challenges that have been a big mess too, just that like the patient coding has changed week to week. Even identifying who has COVID, interpreting what does it mean. So, somebody who comes in with a COVID test in April is different than one that comes in March because tests weren't available. So only sicker people were getting tests. Even today, there's a lot of disparities across hospitals in terms of whether everybody admitted to the hospital even gets a COVID test. Some of the tests were bad. And some people were just you didn't give them a test because you presume they had COVID, and you're trying to dig through text in the charts. So we have the early stages where we had the most patients are just a huge, big data mess. But in principle, AI can be used to try to go through the charts and try to, grab the text and get a better picture of what was happening to these patients, where like this, the standard diagnostic and procedure codes don't necessarily tell the whole story.
Well, thank you. Now, Linda, how about from your perspective?
Yeah, I think COVID has really exposed some serious issues with the healthcare system. Obviously this reactive sort of healthcare mode is failing us. I think it also has exacerbated sort of the inequities in access to healthcare with communities of color and our society's most vulnerable. So if anything, the pandemic has sort of given us an opportunity, if not a necessity, to shift that paradigm to more proactive healthcare. And I think proactive healthcare requires organizations to be able to sort of look around the corner and see the depth and shape of their future risk. But with enough details, the who, the what, the when, the why, in order to do something about that. And I think that has to be at the population level as well as at the specific member level. And decisions can be made with that kind of information that might be financial or programmatic or structural or organizational. Specifically with COVID, Susan outlaid a lot of stuff with respect to COVID patients, but there's the sort of unseen sufferer population. And so we've been working with our clients to identify those patients that are, most at risk due to deferred care through COVID, at escalating health issues, and then enabling them to target the most effective outreach through the lens of SDOH to understand either constraints, access, or lack of access issues, so that they can target the most effective sort of approach and alternative modes of care.
Great. And Colt, how about from the health plan perspective? What are you seeing?
Sure. Maybe just to circle around quickly to your initial question. I mean, certainly you had a great list to kick off the meeting with, and when we think about where we are with respect to COVID and the pandemic, there's many applications of AI around the world, from vaccine development and testing, identification of hotspots, and robots that deliver food and medicine. So I'm hoping that those three end up having the largest human impact on COVID. But I do want to kind of pile on to the comments about the current issues in data flow in US healthcare. So as an insurance company, we are concerned not only about COVID, but about all diseases and all populations. And I think it's good to be optimistic about what COVID is teaching us, right? COVID is demonstrating very clearly we don't have the systems in place, we don't have the free-flowing data necessary to not only do research or monitor in many instances, but really to affect and manage care if we ever end up in a worse place than we've been. So when I think about the opportunities here, I think about it from the perspective of aggregating the clinical records that we have about individuals and making them accessible to frontline providers and, frankly, to the member patients themselves. And that's in line with new CMS mandates. So CMS is wanting the healthcare system to move in this direction. I also think in terms of the growing virtualization of care. So Linda mentioned the preventive and primary and chronic care that's not being received today because of concerns around the pandemic. We've seen a very steep decline in those areas. And so understanding the impact of that over the mid and long term is going to be critical for health plans and our public health institutions and federal government. From an AI perspective, I am wondering if over time, if we increasingly rely on virtual care, text and telemedicine and video consults, will we have new data sources for AI to work with? And is that a new opportunity to free the data within the healthcare system to do the types of things that Susan is describing?
Yeah, very interesting. Let's dig into that a little bit more, because there's been a lot of talk about sort of the post-lockdown phase of this, and this deferred care, chronic care during this time, and the effects of that. So how about we begin with Linda? How are you guys? How's PREDICTIVE thinking about that? All these folks who have deferred care have had lack of access to care for the last several months. What role do you see PREDICTIVE playing with the payers and providers in this context to figure out who's going to be at high risk of as a consequence of the lockdowns and stay-in-home measures?
Yeah, thank you. So I think a broad range of healthcare issues have been postponed. Colt mentioned a huge drop in sort of a preventative care. I think in our customers' data, we're seeing 40 to 50% drop. Without routine care, people with chronic conditions are only going to worsen. And so what we're anticipating is, there's the reactive approach where you've got a surge in healthcare as people come out of COVID and need to respond to their worsening conditions, or the opportunity for us to sort of orchestrate that reentry in a targeted way. So anticipating, attracting and prioritizing the most important care for those members. And so PREDICTIVE works with our customers to do that. We're looking at unseen sufferers, if you will, those that have had deferred access to care, have gaps in their care, but that are most at risk, and then prioritizing those for the most effective kinds of either form of outreach or alternative modes of care, whether that's in-home, telehealth, or providing access to transportation to a safe place to do that. Obviously taking into account, anyone with underlying conditions that would be at higher risk for repercussions from COVID. The other side of that is anticipating and thinking about, the new protocols in play. We won't be able to orchestrate as many people back into the system. We might want to look at, non-emergent procedures and really think about how we work with, between health plans and providers in their network to actually bring that revenue back into the system. But obviously we're going to want to manage insights that allow that, providers not to burn out, for scheduling systems not to blow up, for us to not put at risk additional patients to a second surge of COVID. And so managing that flow, and I think, predictive AI capabilities are, useful in this way in terms of managing, and making sense of the data. Again, what data you can get to for planning any of those scenarios, and then connecting it really to the right action.
And Colt, how about you? We'll go back to you again on just how the plans are thinking about AI in the context of sustainability planning in this type of context.
You touched on some of the more critical areas for us. So certainly understanding the health risk that's being created by the restriction in care, and understand what that means for individuals long term, but as well as populations as a whole, that we need to manage the risk and support the care of over time. Is a critically important area that is going to take more time to fully evolve. The second area where we're focused on applying AI is better understanding the utilization bubble and understanding when that might occur, if it will occur, as member patients return to the healthcare system. So those are two of the more critical things that we're focused on at this point.
Great. So then, one of the interesting issues I find, we just did a piece on this at Chillmark, is this issue of the distribution shift or drift and population health features. And so essentially where we have population-wide health effects, such as the pandemic, made sufficient number of people sick with potentially some long-term sequelae or consequences of the virus. Now these population features are going to be different from what we trained algorithms on prior to the pandemic. There's this shift in sort of the distribution of health features or characteristics of these populations. So I was wondering, for Linda and Susan, you know, what do we do in this context, and how can we make sure that we can trust in the validity of outputs of our analytics based on AI, and what are the measures that are being taken to deal with you know, there's this change in utilization and sort of the data drift that's been a consequence of this pretty massive sort of impact of the pandemic. So
yeah, excuse me. Let me take it from a high level, and then maybe Linda can jump in from a specific level. So this issue of models being unstable and unreliable is something that's been a big focus of the applied machine learning literature for the past couple of years. So I work a lot across a lot of different industries. One place this comes up is like the financial sector. If you're trying to do credit scoring, well, if you're going to have a business cycle that's coming and going, and like now we have that, you know, like you've never seen before. And so if you have a black box predictive model that's just looking for correlations in a stable environment, it may not work very well when the environment changes. So there's already been a lot of tension in some of these other contexts between building more simple and more interpretable models, and models that have been sort of tried and tested through business cycles, versus models that use more advanced machine learning and AI that the new employees are super excited about and that perform better in the short run, but that sort of veterans of the industry are skeptical of. And so, you know, the answer doesn't necessarily mean sort of the old versus new, or one's good and one's bad, but rather we need to think more deeply about what is the purpose of the model, and are the models actually sort of well suited to adapt to a changing environment. So if you have a model that's kind of more grounded in fundamentals, and that estimates causal effects, those types of effects are sort of more stable. Like if there's the sense that, you know, becoming unemployed is going to relate to your ability to repay, that's a relationship that stays over time. While lots of signals from, everything from, you know, different applications of use your social media profile, or, you know, other types of digital footprints and so on, those types of signals can be more transient in terms of their correlations with underlying outcomes. So there's sort of a general desire to have models reflect more of the kind of underlying, either, you know, economic reality, or in health, the underlying sort of health reality, rather than just go fishing across a lot of different correlations. Now, the question then becomes, how can I get some of the benefits of modern AI and machine learning models if I desire this structure? One set of things is just trying to impose properties, like if something should be monotone. You know, you don't want your credit score, you don't want your credit decision to be that you get more likely to be rejected if you pay off your loan. You know, so you need things to be increasing in the variables that should relate to them. You may also restrict the features that go in, but then use machine learning to create composite features that are trained against another type of objective. So you can take a lot of the less structured data, if you like, and try to put it into an index, but then control more carefully how that index goes into the final model. There are also techniques that I've looked at in my own work around trying to reweight the data to reduce some of the correlations in the data that might not be stable over time. And so if you reduce those correlations, you force your model to focus more on direct effects and to put less emphasis on kind of multi-way correlations that might not hold up in changing conditions. So high level is that the lack of a completely clear, well-developed framework for making AI robust, stable, interpretable, causal, and reliable across different environments has led to I think what I would characterize today as a set of band-aids, and also has led to the need for specialists and domain experts to really be in the driver's seat. You can't just outsource this to 15 new master's students and let them run with the data who know about machine learning but don't know about the domain. Over time, I think the aspiration of machine learning and AI would be to have more robust techniques that didn't require so much, kind of expertise and care. But I would say the state of the art today is that if you're in an important applied environment with a changing environment, you need a deep collaboration between domain experts and the modelers in order to get anything that you would consider reliable. And even so, if the world changes, you need to retrain your models. Like there's nothing, you don't stick with the same credit scoring model you had 6 months ago, today. Like you need to change your models. You don't stick with the same hotel cancellation models, that you had 6 months ago. It's like, you have to get creative.
Great. And Linda, how about what are you seeing?
Yeah, I agree. I think if anything, COVID has really highlighted that we need to be flexible and that things will change. It'll continue to change. At Prealize, we train our models on years and years of data, and obviously that's historical data. And also, 21 million lives so far, but also everybody's specific client population. We predict like 12 to 18 months out, but our algorithms take into account missing data. They take into account gaps in care. They take into account missing prescriptions and things like that. So we sort of expect this lack of utilization, if you will. We're looking for it. And so that's been really, a good thing for us in terms of protecting. But I think to really trust predictions, we need to have monitoring and quality systems in place so that one understands where the guardrails are on your predictive algorithms. And we can measure the potential impact. We test. Like we have created synthetic databases that, anticipate short-term, mid-term, long-term, all different types of gaps in care and major blind spots, and have still seen very high levels of accuracy. So I think anybody buying a solution from somebody should at least expect that kind of continuous monitoring and improvements. But again, even if we get to a new normal of patterns, I think our AI has to be more nimble, as Susan described, and I'm sure, data science teams throughout, the healthcare world are, anticipating the need to think about this going forward.
Great, thank you. And that's a good segue to the final question I'd like to ask, and this one's also for Susan. And I mentioned earlier this bridge between health IT into public health in the communities, and this notion of precision public health. And I know you've been looking at a lot of the the obstacles and difficulties of that, and how we can address those, and where you see AI playing a role in thinking about these health inequities and social determinants, especially post-pandemic, given this kind of almost trifecta of crises we're facing right now with the pandemic, the economic impact, and now the issue, Black Lives Matter, and this really, the importance of focusing on these social determinants and race and so forth. And so how can we use AI and to extend our powers beyond the health IT system into communities?
Yeah, so I think Linda already forecast this issue of sort of increasing telehealth and interaction. And I guess before this whole crisis, my lab at Stanford has been looking at ways to use digital interaction to improve access and improve problems of inequality, whether it's access to training or job search or education for low-income students. And so there's, digitization creates inequities, and we've seen that the lack of broadband, for example, has been a huge problem during this crisis. On the other hand, we do have fairly widespread access to phones in the US. And certainly for even myself as a working mom, I'm privileged to have great healthcare, but if I'm running around between meetings trying to get my 3 kids healthcare, the delays and the challenges of waiting for phone calls and answering phone calls and getting to the doctor still create challenges even for a very privileged person like myself. And if you have a much harder time getting off of work and getting transportation, it can be a very large impediment for people who are struggling to make ends meet. So I'm very hopeful, actually, that out of this pandemic, we've finally broken through the log jams that were preventing us from getting much more time-efficient access to care. We need to value the time of the patient. And forcing a patient to take 3 hours to access care, getting there, waiting, accessing, getting home, is just too much of a cost to put on the patient. And nothing in the system today has really valued the time or the kind of organizational capability, if you like, of the patient who has to navigate, lots of different hurdles to get access. So I'm very hopeful that we can come out of this because of just the necessity that we've had to try to reach people not in person, that we will be able to build tools that can help people access outside. There was a question in the chat about chatbots. Again, they are the ones that a lot of the chatbots that we interact with today are pretty stupid and pretty frustrating. You get to any kind of complex question and they just throw you to wait in line for a call. So the current state of affairs is not great, but I have certainly seen myself better incarnations of that across sectors in the economy, where the chatbots can get better and better and can be applied to the places where, part of the thing is you have to sit on hold for 20 minutes to get the answer to a simple question or to carry out a simple activity. And if we can kind of, again, economize on patient times and remove the frictions, focus on these digital tools to remove frictions and preserve the human time for the part that it needs to be human, and meet people where they are. If you're a working mom, you need to be able to talk to that mom, at the time when she's not at work and she's, not juggling 15 things. You need to be able to cut out those frictions to reach her. We see a lot of empirical evidence that that women in particular kind of implicitly show higher travel costs for lots of activities, whether it be job opportunities and so on. And that travel cost for women, I see appears to come from all these other obligations that you might have, and it's very expensive to pay babysitters and other things. So I guess I just really hope that we all work together after the pandemic to provide much easier and lower cost from a provision perspective, preventive care and access that doesn't put so much burden on poor patients.
Great, well, thank you. So now we'll open it up to some of the questions the audience has asked. And I see the first one we have, or John, did you prioritize one, or you just want me to start from the top?
As long as you can see the questions, just look through them and see which ones you think fit the discussion the best and are the most important for the community to hear.
So I'll just start for the first one. We'll just go with the first one, one at the top of the list. Ren O'Brien Jr. asked, despite all the optimism about AI, ML, can you provide us with some known use cases for driving care outcomes from these solutions? So do you guys have any top of the mind examples that would demonstrate sort of a strong ROI, is what I'm guessing they're asking? That's a particularly important question in the context of hospitals and providers and so forth taking a hit during the pandemic, what are some ones where we can really drive ROI for the users?
Yeah. Well, obviously, when we've targeted the right outreach and clinically impactable outreach to the right kind of members, we've had some really good outcomes for patients that we've seen with our clients. You know, members who had chronic conditions but were managing their diseases and were predicted to rise in cost and worsen in terms of their health. You know, that outreach was sort of at the right time for the right reasons and engage somebody in changing their behavior. So, you know, we call her Maggie. She's an example that we have in a lot of our materials, but she's a real human being that was suffering, you know, from obesity and chronic pain and, you know, depression, and was, you know, on opioids and, you know, experiencing a lot of challenges with her health. But was not, you know, like when the care management reached out, it wasn't, her health was salient enough, but she wasn't already in the hospital. And so smoking cessation, changing her behavior, getting on alternative, you know, pain medicines, that really brought her costs down from what was predicted to be like $88,000 the coming year to $8K, and a significant drop in utilization in the system. And that's just one of many that we collect as we do member stories with our customers.
Does anyone else have anyone, or would you like to go to another question, panelists?
I'll jump in terms of maybe a little more routine and preventive care answer to the question. So at Premera, we use email to predict who is likely to close a recommended care gap on their own versus through prompting. And those are for things like routine diabetic care, filling prescriptions under a HEDA standard for those with cardiovascular disease, you know, receipt of routine screenings, mammographies, etc. And we we use that prediction in order to allocate resources to those who aren't likely to go out and proactively receive the care on their own. And so we can dedicate time and attention either as Premera or in partnership with their primary care provider group. So that is an area where we have focused and we've seen care gaps close.
Great. And so Colt, I see a question that I think this might be interesting for you, from Jeff Ellington, on how do you see AI informing benefit plan design, and how can its leaders assist on making that a practical reality?
So it is not, to my knowledge, in health plans, broadly speaking, in informing benefit design today. But I would say we're applying AI and ML as a precursor. One of the things that we're doing is aggregating EMR records and preparing longitudinal records to support CMS mandates. And through that effort, as well as others, for instance, under the Accountable Care Act, understanding underlying conditions of members is becoming increasingly important. And so we actually are receiving new information that we didn't historically have that can help inform us about their care needs. And similarly, we're branching out to social determinant of health data to better understand what are barriers to care, not necessarily the clinical conditions, but other barriers that may be standing in the way. So I'd say we're building the foundation to be able to use AI and ML to better inform and develop benefit plans in the future.
And this could be our last question, since we only have 2 or 3 more minutes left. But there's a question about what should be the new standards for leadership in the post-COVID environment, and where would that leadership come from? So you might want to look at different levels of leadership. But Linda, do you have any thoughts, or Susan?
Yeah, I'm thinking that the pandemic and sort of thinking through post-COVID, that, you know, I'm seeing a lot of opportunities with healthcare leaders kind of embracing a new reality and thinking about, what this new world is going to look like. I'm hoping that the pandemic is a catalyst for a shift to more proactive healthcare, that we're, moving away from just managing sort of the reactive kind of triggers and really thinking about how do we create an ecosystem that, addresses some of the things where providers were hammered on, their high revenue, but we could actually have orchestrated, a more thoughtful approach to care while a pandemic is occurring. And I think that people are really open to discussing that.
Great. Any others?
I'd like to see more leadership from the public sector as well. We just have been very slow in certain things, like for example, funding of outpatient trials has been very slow. We haven't known who would really take the lead for repurposing generic drugs where there's less of an incentive from the private sector. NIH has been slow to get money out. We weren't really set up for sort of quick turnaround. And there's a lot of still questions even today about who's in charge. And, none of our organizations were really ready to be nimble, and they just took a while to get organized. So if we could have a little bit more of a plan for what we do, then we could focus on executing the plan, which is hard enough, rather than just spending months trying to decide who should be in charge of the plan or wondering if someone else is actually going to be in charge of the plan.
Great. Well, thank you. I see we're now at 1 o'clock Eastern time, so our webinar will conclude, but I wanted to thank our panelists for their fascinating insights and for PREDICTIVE for sponsoring the webinar today. I think we all learned a lot, and thank you for your questions as well.
Thank you for hosting.
Yep, thank you everyone for joining today, and we look forward to seeing you at one of our next webinars. Thank you to Linda, Susan, and Colt for joining us today and sharing their insights from all the work that they do and all the great lessons that they have learned both from this process as well as a career in this side of the industry.